Hello, this is Dr. Oviedo. Today we are going to review cardiac valvular pathology. We're going to start with calcific aortic stenosis. Calcific aortic stenosis is the most common valvular abnormality. It can present as angina, congestive heart failure, or syncope. It can affect an anatomically normal or bicuspid valve. The risk factors are similar to atherosclerosis and include hypercholesterolemia, metabolic syndrome, end-stage renal disease, diabetes mellitus, and age. Let's take a look at the pathology. Here's our valve. This, of course, is an aortic valve with 3 leaflets. You can see there are extensive nodular calcifications on the leaflets. The free edges of the leaflets are not involved. Now I want to take a look at the histology of a normal aortic valve in order to understand the pathogenesis of calcific aortic stenosis. Here's a whole mount of an aortic valve. You can see this is the aorta, this is the aortic valve, this is the left ventricle wall. Here's a microscopic photograph of the valve. You can see it has valve interstitial cells which maintain the extracellular matrix. I've circled the nucleus of one valve interstitial cell right here. Now I want to discuss calcific aortic stenosis pathogenesis, which is a response to tissue injury. Here again is our valve interstitial cell. When there is tissue injury with mechanisms similar to atherosclerosis, including endothelial injury and lipid infiltration, the valve interstitial cell will respond by causing fibrosis and calcium deposition in the leaflet. I've drawn that here as these pink calcific deposits. This will progress over years and produce the picture at the bottom. This is calcific aortic stenosis, where the leaflets are thickened and calcified. Let's go on to mitral annular calcification. This will have calcific deposits at the base of the leaflets. It does not usually affect valve function. Let's go on to the pathology. Here's our valve. You can see this is a mitral valve with 2 leaflets. Here are the calcifications at the base, which is the same thing as the insertion of the leaflets. Let's go on to mitral valve prolapse. This is usually an incidental finding, which means it's something you find when you happen to be looking for something else or at another structure. It can rarely lead to complications. Approximately 3% of patients may develop infective endocarditis, mitral insufficiency, stroke due to embolism of leaflet thrombi, or arrhythmia. The etiology is usually unknown. Rarely it can be associated with Marfan syndrome, which is caused by fibrillin 1 mutation. Let's take a look at the pathology. Here is our heart. First of all, let's orient ourselves by looking at normal structures. Here is the right ventricle, here is the left ventricle, here is the interventricular septum, here is the left atrium, here is the aorta, and aortic valve. This, of course, is the mitral valve with a markedly ballooned leaflet that would, of course, protrude into the left atrium in life with mitral valve prolapse. Let's go on to rheumatic fever. We will discuss both acute rheumatic fever and chronic rheumatic heart disease. This is a complication of group A Streptococcus pharyngitis. Let's discuss acute rheumatic fever. This generally occurs 10 days to 6 weeks post group A streptococcal pharyngitis. You can have multiple findings including migratory polyarthritis, pancarditis, subcutaneous nodules, erythema marginatum of the skin, and Sydenham's chorea. We will be reviewing the findings in the heart. Let's discuss the pathogenesis of acute rheumatic fever. Here I have a drawing that represents the group A Streptococcus pharyngitis. You can see the bacteria infecting the pharyngeal epithelium. This infection can cause generation of cross-reactive B cells, which produce cross-reactive antibodies and cross-reactive T cells. These cross-reactive antibodies and T cells can then cause damage in multiple organs. The episode where you are having the damage to the multiple other organs is called acute rheumatic fever. Here I have a drawing demonstrating the autoimmune reactions on the heart valve. You have antibodies which attach to the endothelial cells and cause the valvular endothelium to express VCAM1, which then causes the cross-reactive T cells to adhere to the endothelium and initiate an inflammatory response. These inflammatory processes cause remodeling of the heart valve. Let's take a look at the pathology. Here is a normal mitral valve for comparison to the pictures of the pathology. In this photograph, you can see the findings of acute rheumatic fever, which are multiple small vegetations along the line of closure of the mitral valve. I put in arrows here, here, and here to highlight the location of the vegetations. The vegetations are composed of platelets and fibrin due to autoimmune mechanisms. After years to decades, you can get the findings of chronic rheumatic heart disease, which are the thickened line of closure, which I'm showing right here, and the fibrosed chordae tendineae, which I'm showing right here. Also, you can get fused commissures, which I am showing on this picture, in the aortic valve. You can see the fused commissures here and here. Let's go on to discuss the findings in the heart. Acute rheumatic fever causes a pancarditis. Here is our section. You can see here is the Aschoff body, which is composed of macrophages and T cells. Here I've shown an Anichkow cell, which is a macrophage with elongated chromatin. I've put an arrow on the elongated chromatin. This is simply a finding you can sometimes see in an Aschoff body. Here I've shown endocarditis, which is basically endocardium with edema and lymphocytes. Down here I've shown myocarditis, which is myocardium with edema and lymphocytes. Myocarditis in acute rheumatic fever is antibody-mediated against cardiac myosin. The myocarditis of acute rheumatic fever will generally resolve, but the valvular lesions do not resolve. Let's go on to bacterial endocarditis. The pathology of bacterial endocarditis are friable, bulky vegetations on the heart valves. Friable means that something falls apart when you touch it. The pathogenesis is that bacteria have adhesins on their surface that can adhere to intact valvular endothelium. For example, Staphylococcus aureus is one of the bacteria that has these properties. Once the bacteria have adhered, they can trigger inflammatory reactions with platelets and fibrin deposition. In intravenous drug users, the pathogens gain transient access to the bloodstream and then adhere to the right-sided heart valves. There, they can produce an inflammatory reaction and promote platelet and fibrin deposition. These vegetations can embolize to other parts of the body. Bacterial endocarditis can also affect any damaged valve. The organisms involved in bacterial endocarditis are covered by Dr. Elfman in a separate lecture. Let's take a look at bacterial endocarditis pathogenesis. Here is a drawing demonstrating what can happen when you have intravenous access to the bloodstream and contaminate it with transient bacteremia. You can see on the right, going from top to bottom, the bacteria can adhere to the endothelium and cause an inflammatory reaction with platelets and fibrin. On the bottom right of the drawing, you can see little fragments that are breaking off from the vegetation right here and right here. These can then embolize to other parts of the body. The embolization of the vegetations can go to the lungs, for example, if it affects the right-sided heart valves, or it can go to systemic organs if it affects the left-sided heart valves. For example, it can go to the brain and cause brain infarction. You can also get valve destruction. Let's take a look at the pathology. Here is our heart with bacterial endocarditis. First, let's orient ourselves. This is the left atrium. This is the left ventricle. Here is the mitral valve. Here are the chordae tendineae. And here are the papillary muscles. Here, of course, these numerous large red lesions represent the vegetations on the valve leaflets. Bacterial endocarditis can generally be distinguished from the non-infectious causes of endocarditis because bacterial endocarditis tends to have very large vegetations. The vegetations of bacterial endocarditis are composed of platelets, fibrin, bacteria, and neutrophils. Here on the right, I have an ultrasound of a heart with bacterial endocarditis on the mitral valve. First, let's orient ourselves. This is the left atrium. This is the left ventricle. Here is the right atrium, and here is the right ventricle. This is a circle around a very large vegetation of the mitral valve. You can see how this could break off and embolize to other organs. Let's go on to discuss non-bacterial endocarditis. First, we'll discuss non-bacterial thrombotic endocarditis. This is also known as Rheumatic endocarditis. Rheumatic endocarditis is an old term but is still commonly used in clinical practice. This generally arises in a debilitated patient and is likely due to a hypercoagulable state. The risk factors are cancer and sepsis. The pathology is small sterile thrombi on the line of closure of the cardiac valves. Let's take a look at the pathology. Here is our heart. First, let's orient ourselves. This is the left atrium. This is the left ventricle. Here are the mitral valve leaflets. Here are the chordae tendineae. Here, of course, are the thrombotic vegetations along the line of closure. The vegetations in non-bacterial thrombotic endocarditis are generally composed of platelets and fibrin and occur in a patient with a hypercoagulable state. Let's go on to discuss Libman-Sacks endocarditis. This is associated with lupus. This is composed of small vegetations which may occur on the undersurface of atrioventricular valves, valvular endocardium, chordae tendineae, and mural endocardium. Let's go on and look at a picture of the pathology. Here is our heart. First of all, let's orient ourselves. Here is the left atrium. Here is the left ventricle. Here are the mitral valve leaflets. I've marked one chordae tendineae right here. The pathology, of course, are the multiple small vegetations present on the leaflets and the chordae tendineae. The vegetations in Libman-Sacks endocarditis are composed of platelets and fibrin and immune complexes. I've put the immune complexes in parentheses because you can't really see that in a microscope when you're looking at a specimen. Okay, let's do a review of what we've just discussed. First, I have acute rheumatic heart disease, which has small vegetations along the line of closure. Here is bacterial endocarditis, which has large vegetations on the leaflets. Non-bacterial thrombotic endocarditis has small vegetations along the line of closure. Libman-Sacks endocarditis has small or medium vegetations on the leaflets and the chordae tendineae. Please note that there is, of course, some overlap in the appearance of these different types of vegetation. The clinical history will, of course, help you distinguish some of these. Also, in clinical situations, laboratory studies may also help you distinguish among these different entities. The sources of images I have used in this lecture include Radiopedia, the Peer Digital Library from University of Alabama, Birmingham, Virtual Microscopy Database, and of course, Robbins' Pathologic Basis of Disease. Okay, that's it.